Now, may I request Dr. Samyukta Sadasivan, Assistant Professor of Ophthalmology in Government Medical College, Thrissur, to speak to us on the topic Diplopia in comitant strabismus.
Good morning. So, strabismus, which is comitant, signifies that the misaligned eyes maintain their abnormal relation to each other in all directions of gaze. So, when you measure the deviation, the magnitude will be the same in all gaze positions. So, here the efferent pathways are essentially normal, and the problem lies in the afferent pathway. So, the central mechanism mediating fixation and fusional reflexes is either underdeveloped or has broken down. So, that usually diplopia is very unusual in comitant strabismus. Why? Because of development of neural suppression mechanism, or due to development of amblyopia in children, or due to anomalous retinal correspondence. There are situations where you can expect a diplopia to occur in comitant strabismus, and that happens spontaneously. Heterophoria when fusion fails, when suppression fails, in association with a significant change in the degree of strabismus, or in cases of long-standing strabismus, when a disruption in visual adaptation happens, rarely after orthoptic treatment and also post-operatively. So this was a 12-year-old boy who presented with a history of binocular diplopia of 1 week duration. There was no contributory family history or any precipitating event. His squint evaluation revealed 45 prism diopters of esotropia for both distance and near, alternating well, full extraocular movements. Worth 4-dot test revealed that the patient said he was seeing 5 dots, suggestive of binocular diplopia. His best corrected visual acuity was 6.6 and N6. Cycloplegic refraction was within normal limits. Fundus exam also suggested nothing abnormal. So this being a case of acute onset ESO deviation, we went ahead with an MRI that turned out to be normal as well. So a diagnosis of acute acquired comitant esotropia was made. Now, this is a clinical entity which mandates good attention these days, especially after the post-COVID home confinement times, and increased number of cases have been reported ever since. So the clinical features, salient features include acute onset, association with diplopia for both near and distance, comitant nature of the deviation with the difference less than 5 prism diopters in all gaze positions, values being similar for both distance and near. And it is a large angle esotropia typically with full extraocular motility in all directions, seen usually in older children more than 5 years and also in adults, and accounts for nearly 0.3% of childhood strabismus. Etiology is essentially elusive. Mental stress, increased screen time, and decompensation of esophoria have been hypothesized to be causing this. So this is an interesting article which got published from Kerala in the COVID times. Similar reports have been published in the past as well. All of them point towards the fact that the stronger convergence and lack of distance stimuli create an imbalance between accommodation vergence mechanics, and that further leads to dynamic activation of medial rectus muscles. So regarding the course and prognosis, there is a 6% risk of an underlying neurological disease, so neuroimaging is mandatory before you take up the patient for any surgical intervention. Recovery spontaneously is unusual. The main concern in children is the possible development of suppression. So as step 1, you can advise refrainment from near work, reduce screen time and reassess, and a waiting period of 3 to 4 months is advisable before taking up for any surgery. And you have to differentiate AACE from these different conditions: sixth cranial palsy, cyclic esotropia, divergence insufficiency, refractive esotropia, spasm of near reflex, and finally myasthenia gravis. With early intervention, this condition has got an excellent prognosis. Spectacle correction has to be considered after going for a thorough cycloplegic refraction and attending to the accommodative component. Botox is a viable option to maintain binocularity during the waiting period. And if the amount of deviation is close to 15 prism diopters, you can even try a base out prism to maintain binocularity till the deviation stabilizes. Surgery, as I told, after 3 or 4 months till the deviation stabilizes. And another interesting point is that we have to go for a wider surgical dosage than those reported in dose response tables for esotropia. So Botox, this is a rough guideline. You can give a range of 4 to 7 international units for deviations ranging from 30 to 60 prism diopters. Monoocular upper lid ptosis is a concern, but it is something which resolves on its own. So this child was given 5 international units of Botox A under GA to his left medial rectus. He developed a ptosis in the immediate postoperative period, but it was transient and resolved on its own. However, at 2 months post-op, he was orthophoric. So this is a second patient, a 30-year-old artist who gave a history of 5 years of sudden onset ocular deviation with horizontal diplopia. He gives a history that he developed these symptoms immediately after working with phone for 5 hours continuously. He himself being an artist, he used the phone for drawing pictures. And on that particular day, he developed this sudden onset left inward deviation, right eye inward deviation with associated horizontal diplopia. And he consulted elsewhere, and in these 5 years, he underwent 2 procedures, like Botox was given twice. So on evaluation, cover test revealed alternating ET with left dominance. Prism cover test showed 30 plus 40 prism diopter CT for both distance and near. EOM was full. Visual acuity, best corrected visual acuity 6.6. Cyclorefraction showed normal retinoscopy shadows. And fundus exam was within normal limits. Again, MRI brain was done. That was also normal. So this was an adult whom we diagnosed with AACE. Since Botox was already tried, we went ahead with a recess resect procedure in the right eye. Now he has a residual deviation of 35 PD ET. Now the other eye is being planned for R by R. So this is a common scenario, nothing new. A 14-year-old boy with occasional outward deviation of left eye, history of occasional diplopia and aversion to bright light. So his cover test revealed, his Hirschberg's test revealed no angle to 20 degree LXT. Cover test showed alternating exodeviation with right eye dominance. EOM full, PCT for distance 35 PDXT and for near 30. Visual acuity 6.6 both eye. BSV showed left suppression at the time of examination. Fundus examination was within normal limits. So he was diagnosed with fair control intermittent exotropia. Recess resect was done in the left eye. Post-operatively, orthophoria was achieved. So we know intermittent exotropia is the second most common type of strabismus. A large exophoria which is controlled by fusional convergence mechanism breaks down to manifest exo when the patient is fatigued. Typical symptoms, transient diplopia or a diplophotophobia. They say that the bright light dazzles the retina and that breaks fusion and the patient will experience diplopia. This is a Buren's classification of IXT, basic intermittent XT, true divergence excess IXT, pseudo or simulated divergence excess IST, and convergence insufficiency IXT. This Newcastle control scoring system is a reliable method for grading the severity of IXT. And as you work up, go for a prolonged alternate cover testing, do a patch test for 30 to 45 minutes, and to confirm high AC by A ratio true divergence excess type of IXT, you may have to go for lens gradient method, that is a +3 diopter near ad test. Management, start up with cyclorefraction and give corrective lenses accordingly. Over minus lens therapy is to stimulate accommodative convergence, and prisms and part-time occlusion can be considered. Finally, you can go for symmetrical bilateral surgery or unilateral recess resect. So this is a fourth case, a 67-year-old gentleman who presented with outward squinting of left eye, 1 year duration. No contributory history, no addictions, no prolonged medications. His cover test revealed alternating kind of exodeviation with full EOM, PCT for distance 35 PDXT and for near 40 PDXT. Best corrected visual acuity 6.6 N6. Worth 4 dot test revealed left suppression. Dilated fundus exam was within normal limits. He did not have any comorbidities either. So this was his FAT scan. All the photographs of past suggested orthophoria. So this is probably a decompensated childhood strabismus in adulthood. Advancing age per se is a causative factor that causes some imbalance between the sensory and motor binocularity. So here, probably the accommodative reserves have become deficient with age. His convergence response is affected. Refractive changes can also be a cause. Any change that forces fixation with the patient's previously non-dominant eye. So this condition has been named as fixation switch diplopia. Other causes are trauma, illnesses, or medications and alcoholism. This is an interesting article which we found in American Orthoptic Journal, where they have told in detail about decompensated childhood strabismus manifesting in adulthood. So management, first and foremost, after the essential routine investigations, you have to rule out neurologic disorders. Prisms can be tried in small deviations. Fresnel prism foils can serve as a temporary or a permanent solution in larger deviations. And Botox again can be tried. Finally, resort to surgery if the deviations are more than 10 prism diopters, preferably with the adjustable sutures. Thank you.